In a breathing emergency, a person's respiratory function can become so impaired that life is threatened. Breathing emergencies are progressive. If the person does not receive care quickly, their respiratory function will become increasingly worse. Respiratory distress, or increased work of breathing, is the earliest stage of a breathing emergency. Many conditions can cause respiratory distress. For example, a person experiencing an asthma attack, a severe allergic reaction, a heart attack, or a panic attack may have respiratory distress. If not treated, respiratory distress can progress to respiratory failure. In respiratory failure, the respiratory system is beginning to shut down. There may be some ventilation, but it is not effective, and as a result, the blood contains too little oxygen, too much carbon dioxide, or both. If respiratory failure is not relieved, respiratory arrest can occur. In respiratory arrest, breathing stops. Cardiac arrest will soon follow unless respiratory function is restored. You can identify a breathing emergency by watching and listening to the person's breathing and by asking them how they feel. The person's breathing may be slower or faster than normal, or unusually deep or shallow. It may be difficult for the person to speak in full sentences. You may hear gasping, wheezing, gurgling, or high-pitched noises. The person may tell you that they feel short of breath. In a child, you may also see widening of the nostrils when breathing in, use of the chest and neck muscles to assist with breathing, and grunting. The person's general appearance may also give you clues that they are experiencing a breathing emergency. The person may lean forward with the hand supported on their thighs or another surface to make breathing easier. This is called tripod positioning. The person's skin may be cool and clammy, and it may appear flushed, pale, gray, or bluish. The person may be irritable, restless, or anxious. There may be changes in the person's level of consciousness. You do not need to know the exact cause of the breathing emergency to provide initial care.
Hi, I'm Joe. I'm a certified lifeguard. Are you okay?
When a person is having difficulty breathing, activate the EAP
Call 911, get the equipment.
and instruct someone to call 911 and get the emergency equipment. Then, encourage the person to rest in a comfortable position that makes breathing easier, such as sitting up and leaning slightly forward. Provide reassurance, which can reduce anxiety and make breathing easier. Offer to assist the person with any medication they may carry with them for the emergency treatment of a condition such as asthma or anaphylaxis. Administer supplemental oxygen, if it is available and you are trained to do so. Monitor the person for changes in their level of consciousness and breathing, and be prepared to provide care for respiratory failure or arrest and for cardiac arrest.
Caring for a responsive choking infant consists of 5 back blows followed by 5 chest thrusts. To perform back blows, first place the infant's back along your forearm, cradling the back of the infant's head with your hand, like this. Then place your other forearm on the infant's front, supporting the infant's jaw with your thumb and fingers. Do not cover the infant's face. At this point, hold the infant in a face-down position along your forearm, using your thigh for support and keeping the infant's head lower than their body. Make sure your fingers are on the sides of the head and not blocking the mouth. Using the heel of your hand, give a back blow between the infant's shoulder blades. Keep your fingers up to avoid hitting the infant's head or neck. Give 5 firm back blows with each one separate from the others. 1, 2, 3, 4, 5. After back blows, if they are unable to cough or cry, give chest thrusts. First, position the infant between your forearms, support the head and neck, and turn the infant face up. Then, lower the infant onto your thigh with their head lower than their chest. Next, place 2 fingers in the center of the infant's chest, just below the nipple line. Then, give 5 quick chest thrusts about 1.5 inches deep. Let the chest return to its normal position, keeping your fingers in contact with the chest. Each chest thrust should be separate from the others. Remember to support the infant's head, neck, and back while giving chest thrusts. 1, 2, 3, 4, 5. You will need to continue giving sets of 5 back blows and 5 chest thrusts until the infant can cough or cry or the infant becomes unresponsive. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. If the choking infant becomes unresponsive while you're providing care, follow the same steps as you would for an unresponsive choking adult or child with 2 slight differences. First, be sure to use the encircling thumbs technique when giving 30 compressions. Second, if you see an object in the infant's mouth, use your pinky instead of a larger finger to do a finger sweep. And remember, only do a finger sweep if you see an object.
Caring for a responsive choking adult or child consists of 5 back blows followed by 5 abdominal thrusts. Watch as Richard and I demonstrate this care for a choking adult. To perform back blows, first position yourself to the side and slightly behind the choking person. Then, place one arm diagonally across the person's chest and bend them at the waist so that their upper body is as parallel to the ground as possible, like this. This position helps remove the object and allows you to brace yourself if the person becomes unresponsive. At this point, firmly strike the person between the shoulder blades with the heel of your hand. Now, I'll simulate 5 back blows, but I will not use full force as I would if Richard were actually choking. 1, 2, 3, 4, 5. After back blows, if they are unable to cough or speak, give abdominal thrusts. First, find the person's navel with 2 fingers. Then, move behind the person and place your front foot between the person's feet with your knees slightly bent to provide balance and stability, like this. Next, with your other hand, make a fist and place your thumb side against the person's stomach right above your fingers. Finally, take your first hand and cover your fist with that hand. Then pull inward and upward to give an abdominal thrust. Now, I'll simulate 5 abdominal thrusts. Again, I'm not going to use full force. 1, 2, 3, 4, 5. Continue giving sets of 5 back blows and 5 abdominal thrusts until the person can cough or speak or the person becomes unresponsive. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. The technique for a choking child is similar to that of an adult with slight modifications. As always, when caring for a child, be sure to obtain consent from a parent or guardian before providing care. Of course, if they are not available, consent is implied. Oswin is going to help me demonstrate this skill. Ready? You might need to kneel behind the child to provide effective back blows and abdominal thrusts. Here's how you care for a choking child. Remember, I will only simulate the skill. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Good job. If a person is pregnant, too large for you to stand behind and reach around, or if the person is in a wheelchair, you may need to give chest thrusts. Ready, Marla?
Yes.
To give chest thrusts for a responsive person, make a fist with one hand and place the thumb side of your fist in the center of the person's chest. Grab your fist with the other hand and give quick thrusts into the chest. 1, 2, 3, 4, 5. It is important to know that back blows, abdominal thrusts, and chest thrusts are all equally effective for responsive choking, but it may take more than one technique to clear the airway.
3, 4, 5. If a choking person becomes unresponsive while you're providing care, carefully lower them to a firm, flat surface. Then, immediately begin CPR, starting with compressions. Compressions may help to clear the airway by moving the object into the upper airway, where it can be seen and removed. Before attempting ventilations, open the mouth and look for an object. If you see an object, remove it with a finger sweep. But remember, you should never do a finger sweep if you don't see an object, because you might push the object further back. After doing that, attempt 2 ventilations. If the ventilations go in, that is, the chest begins to rise, resume the normal CPR cycle of 30 compressions and 2 ventilations and use of an AED. If the ventilations do not go in, that is, the chest does not begin to rise, then repeat the cycle of giving 30 compressions, checking for an object, performing a finger sweep if an object is seen, and then attempting 2 ventilations. Remember, never attempt more than 2 ventilations during each cycle.
Okay, Chloe, call 911. Tell them 2 people are hurt and one's got life-threatening bleeding, and both are awake.
Okay, 911, life-threatening bleeding, and both awake.
Daniel, down that hallway, there's a bleeding control kit, a first aid kit, and an AED. Go get them.
Life-threatening bleeding and both awake.
911, what's the location and emergency?
Yeah, there's 2 people.
Okay, I'm going to help you, but first, what's the address of your emergency?
I'm at Southside High on Manor Avenue. There was...
Okay, so you're on the Southside High School campus at 445 Manor Avenue in Springfield?
Yes, the cafeteria on the 1st floor by the side entrance on Wilson Place.
And what's the phone number you're calling from?
555-449-9023.
And what's your name, miss?
Chloe.
Okay, Chloe, do you need police, fire, or medical assistance?
Medical.
Okay, tell me what happened.
There was this crash and all this broken glass, and the glass installer guy got cut bad, and the other lady, she's cut too, but it's not as bad.
Okay, Chloe, don't hang up. I'm sending an ambulance right now. To confirm, there are 2 injured people?
Yes, 2. The guy on the ground is bleeding really bad. It's his leg. Alex said that it's life-threatening.
And the other person?
A lady, she isn't bleeding as bad.
Are you with them now?
Yeah, I'm in the hallway. I can see them, though.
Are they awake?
Yeah, they're both awake.
Are they breathing?
Yes, I think so.
Is anyone helping the injured people?
Yeah, my friend Alex is helping. She's trained in first aid. She took off her hoodie and she's pressing it on the guy's cut. And she told the other lady to just put pressure on her own arm until she could help her. And her brother Daniel, he went off to get the bleeding kit and other first aid stuff.
Hang in there, Juan.
Okay.
Good. Make sure Alex keeps applying pressure. Does she need instructions about what to do?
Alex, she says to keep applying pressure. You know what to do, right?
I know. Direct pressure till we get the tourniquet on.
She says she's good. Here comes Daniel now.
Here's what you asked for.
Okay, Alex needs to keep applying pressure until she gets the tourniquet on. Does she know how to use a tourniquet?
Yes, the ambulance. It's coming, though, right?
They're on their way. Chloe, someone will need to meet the ambulance at the side entrance of the school and take them to where the injured people are. Can you do that?
Yeah, you want me to meet them and bring them here, right?
Yes. Will you do that?
Yes. Should I stay on the phone?
Yes, stay on the phone with me until I say it's okay to hang up.
Okay, I'm going to the door. Let me just tell Alex first.
A seizure is the result of abnormal electrical activity in the brain, leading to temporary and involuntary changes in body movement, function, sensation, awareness, or behavior. Signs and symptoms of a seizure may include loss of consciousness, convulsions or uncontrolled movements of the entire body caused by contraction of the muscles, focal movements of a part of the body, vocalizations, and staring. When you recognize that a person is having a seizure, activate the EAP and instruct someone to call 911 and get the equipment. You may not need to call 911 if the person has a chronic seizure disorder and has specifically given you instructions not to call EMS for every seizure. However, you should always call 911 for a seizure if the seizure lasts for more than 5 minutes or the person has multiple seizures in a row, the person was injured as a result of the seizure, the person is unresponsive and not breathing or only gasping after the seizure, or the seizure took place in the water. If you are unsure whether the seizure is life-threatening, call 911 and let EMS make the decision about whether further care is needed. When a seizure occurs on land, remove nearby objects that could cause injury and monitor the person until the seizing stops. Turn the person onto their side into a recovery position if it is possible to do so without injury to them or you. Most seizures only last a few minutes, and the person usually recovers fully without any complications. After the seizure ends, perform a rapid assessment and a secondary assessment and provide care according to your level of training. If the person is unresponsive and breathing, or responsive but not fully awake after the seizure, maintain the person in the recovery position. Then, stay with the person until they are fully recovered and aware of their surroundings, or until EMS professionals arrive and begin their care. If the person is not breathing or only gasping and has no pulse, begin CPR immediately and use an AED as soon as possible. If a person has a seizure in the water, ensure that EMS has been called. Support the person with their head above water until the seizure ends, and assist them from the water as soon as possible after the seizure. Perform a rapid assessment and a secondary assessment, and provide care according to your level of training.
People of any age can suffer from an asthma attack at any time. An asthma attack can become severe and life-threatening. An asthma attack can occur in someone diagnosed with asthma, or may be the first indication that someone has asthma. A person with asthma may have an attack when they are exposed to certain substances or conditions called triggers. Common triggers include respiratory infections, exercise, temperature extremes, allergies, air pollution, strong odors, and stress. Exposure to these triggers causes narrowing of the airways and increased mucus production, making it harder for the person to breathe. Triggers are person-specific. A trigger for one person is not necessarily a trigger for another. A person with asthma should be able to let you know if they are having an asthma attack. Signs and symptoms of an asthma attack include wheezing or coughing, rapid shallow breathing, trouble breathing, being unable to talk without stopping for a breath in between every few words, anxiety and fear, and sweating. If you suspect that a person is having an asthma attack, immediately activate the EAP and instruct someone to call 911 and get the equipment. If the person has an asthma action plan, assist the person to follow that plan. The asthma action plan may include using a prescribed quick relief medication for the emergency treatment of an asthma attack. If so, offer to assist the person to use the medication. Stay with the person and monitor their condition until EMS professionals arrive and begin their care.
Anaphylaxis is a life-threatening allergic reaction that can cause shock and affect the person's ability to breathe. It can be caused by things people come into contact with every day. A substance that is normally harmless to others but causes an allergic reaction in certain individuals is called an allergen. Examples of common allergens associated with anaphylaxis may include foods, particularly eggs, peanuts, fish, shellfish, tree nuts, and wheat, insect stings, medications such as penicillins, and latex. If a person with an allergy comes into contact with an allergen, the body releases an excess of certain internal chemicals. In some people, those chemicals released in the body can lead to life-threatening problems such as difficulty breathing, airway swelling, shock, and even death. Anaphylaxis can develop within seconds or minutes of being exposed to an allergen, although the exact reaction onset may vary among individuals. In some cases, the reactions may be delayed. To recognize anaphylaxis, look at the situation and the person's signs and symptoms. Also, look to see if the person is wearing a medical alert bracelet. If you know that the person has been exposed to an allergen, look for trouble breathing or signs and symptoms of shock. A known exposure plus any life-threatening conditions such as trouble breathing or signs and symptoms of shock equals anaphylaxis. If you think that a person may have been exposed to an allergen, look for any two of the following signs and symptoms: a skin reaction such as hives, redness, or itchiness, swelling of the face, tongue, uvula, or lips, trouble breathing, signs and symptoms of shock, and nausea, vomiting, or cramping. Any two of these signs and symptoms in combination with suspected exposure to an allergen equals anaphylaxis. If you do not know whether the person has been exposed to an allergen, look for a skin reaction or swelling of the face, neck, tongue, or lips. If the person has a skin reaction or swelling and the person is having trouble breathing or showing signs and symptoms of shock, assume anaphylaxis. If you suspect that a person is experiencing anaphylaxis, immediately activate the EAP and instruct someone to call 911 and get the equipment. If the person carries epinephrine for the emergency treatment of anaphylaxis, offer to assist the person to use the medication. While you wait for EMS professionals to arrive, make sure the person is sitting in a comfortable position or have the person lie down if they are showing signs of shock. Stay with the person and monitor their condition until EMS professionals arrive and begin their care.
For some life-threatening illnesses, it may be appropriate to assist a person with medication administration. To assist with medication administration, always follow these steps. Explain to the person or family member what you are going to do. Offer to get their medication. Ask them to confirm that you have the right medication. Assemble the medication device if necessary. And finally, give them the medication to self-administer. Note, you should not administer medications unless it is allowable by state laws and regulations, and you are trained and authorized to do so. Additional training on medication administration is available through the American Red Cross if you need it.
Hypothermia is a potentially life-threatening cold-related emergency that occurs when the body loses heat faster than it can produce it. Typically, the person experiences exposure to cold air temperatures, cold water, or both. Hypothermia can also occur when the weather is not cold, such as when a swimmer in a wet bathing suit experiences prolonged exposure to a windy environment. The person with hypothermia may be shivering, pale, and cold to the touch, but as the condition worsens, the person may lose their ability to shiver, which is the mechanism that allows them to create heat. They may also become disoriented. When you recognize hypothermia, immediately activate the EAP and instruct someone to call 911 and get the equipment. Then, give care for the person with hypothermia according to your level of training. First, move the person to a warmer place. Then, remove any wet clothes, wrap them in a blanket, and cover their head to slowly warm them. Finally, reassure the person and monitor their condition until help arrives.
External bleeding. Bleeding that is visible on the outside of the body can be non-life-threatening or life-threatening. To care for a minor wound when the bleeding is non-life-threatening, place a gauze pad over the wound and apply direct pressure with your hand until the bleeding stops, like this. It may take several minutes for the bleeding to stop. After the bleeding stops, wash the area with soap and warm water. Rinse until the wound appears clean and free of dirt or debris, and then dry the area. Then apply an adhesive bandage or cover the area with a new gauze pad and a bandage like this. First, place a clean gauze pad on the wound. Then, place the end of a roller bandage on the gauze pad at a 45-degree angle and wrap the bandage over the pad several times to hold it in place. Tape, tie, or tuck the bandage to secure it. All right, ready to go.
Bleeding is life-threatening when there is a large amount of blood lost, equal to about 3/4 of a cup or 6 ounces. In a small child or infant, bleeding may be life-threatening when the amount of blood lost is even less. Blood that flows continuously or spurts from the wound is also a sign of life-threatening bleeding. As soon as you recognize life-threatening bleeding, activate the EAP and instruct someone to call EMS and get the equipment. Then, take steps to control the bleeding until help arrives. Depending on the situation, the location of the wound, and the equipment you have, you may use direct pressure, a tourniquet, or both to control life-threatening bleeding. Use direct pressure to stop life-threatening bleeding when the wound is on the head, neck, or trunk. The wound is on an arm or a leg and you are waiting for someone to bring you a tourniquet or no tourniquet is available. Bleeding control kits and first aid kits often contain special dressings called hemostatic dressings. This is a hemostatic dressing. It contains a substance that promotes clotting and can help stop bleeding faster. When there is life-threatening bleeding, use a hemostatic dressing if you have one. Otherwise, use a gauze pad or other available material, such as a clean t-shirt, as a dressing. Place a dressing on the wound and push down with both hands. You need to apply a lot of pressure to stop life-threatening bleeding, so let the person know it can be painful. Sir, this could hurt. Apply pressure directly over the wound until the bleeding stops. Position your body over the wound so your shoulders are directly over your hands with your elbows locked. Push down, using your body weight to increase the pressure. If you need your hands, use your knee to apply pressure. If blood soaks through the original gauze pad, you don't need to do anything, but you can apply an additional gauze pad and continue direct pressure. If that gauze pad becomes soaked, you can remove that one and replace it with a new pad. However, do not remove the original gauze pad that is placed directly on the wound. Also, only add one pad on top of the original. Do not stack multiple pads as this weakens direct pressure. If the bleeding stops before EMS arrives, check for circulation beyond the injury. Note the temperature and color of the skin and ask the person if there is any tingling or numbness. Sir, are you experiencing any tingling? any numbness. Then, apply a roller bandage over the dressing to hold it in place and maintain pressure on the wound. Keep applying direct pressure until the bleeding stops, a tourniquet is applied for life-threatening bleeding from an arm or leg, another person relieves you, you are too exhausted to continue, or the situation becomes unsafe. For life-threatening bleeding on an arm or leg, use a tourniquet. While waiting for a tourniquet, or if a tourniquet is not available, use direct pressure. This is a windlass rod tourniquet. It has 4 parts: a strap, a buckle, a rod, and a clip with a triangle fastener. Now let's take a closer look at the steps for applying a windlass rod tourniquet. Place the tourniquet. Pull the strap. Twist the rod until the bleeding stops or until you can't twist it anymore. Then clip the rod in place. After you've applied the tourniquet, don't loosen or remove it. That should only be done by a medical professional.
Diabetes is a condition that makes it difficult for the body to process glucose, commonly known as sugar. There are 2 types of diabetic emergencies: when the person's blood glucose or sugar is too high, and when their blood glucose is too low. If the blood glucose is too low, then giving sugar can be life-saving. If you don't know whether the person's blood glucose is low or high, it's good to give some sugar. The sugar you give will be life-saving if their blood glucose is low, and will not have a major negative impact if their blood glucose is high. Signs and symptoms of a diabetic emergency include trouble breathing, fast or deep breathing, feeling weak or different, sweating, and a fast heartbeat. If the person is known to have diabetes and is having a diabetic emergency or requests some form of sugar, you can help by giving sugar. First, make sure the person is awake, can follow simple commands, and can chew and swallow. Then follow the general care steps for assisting with medication administration. Finally, give the person 15 to 20 grams of sugar. The recommended amount of sugar is 15 grams for children and 20 grams for adults. If possible, give glucose tablets, liquid or gel. However, other acceptable forms of sugar include 7 ounces of orange juice, 14 ounces of milk, 4 ounces of regular soda, or candy with fructose or sucrose, such as 20 to 25 Skittles, 2 strips of fruit rolls, or 10 to 20 jelly beans. A person having a heart attack may have persistent chest pain, pressure, or squeezing, or isolated unexplained discomfort in the arms, neck, jaw, back, or stomach. In addition to these classic signs and symptoms, a person may have more general signs and symptoms, including dizziness or lightheadedness, trouble breathing, including shortness of breath, pale gray or bluish skin, nausea, vomiting, extreme fatigue, sweating, a feeling of anxiety or impending doom, and unresponsiveness. Although men often have the classic signs and symptoms of a heart attack, women may have more subtle signs and symptoms. The classic signs and symptoms may not be the most obvious, or they may experience the signs and symptoms of heart attack differently than men do. For example, in women, the classic signs of a heart attack may be milder or accompanied by more of the general signs and symptoms. If you think a person is having a heart attack, activate the EAP and instruct someone to call 911 and get the equipment. Then, have the person stop any activity and rest in a comfortable position. Loosen tight or uncomfortable clothing and assist the person with aspirin to help minimize the effects of the heart attack. First, make sure the person is awake, can follow simple commands and can chew and swallow. Then follow the general care steps for assisting with medication administration. Next, give the person 2 to 4 81 milligram low-dose aspirin tablets. So that's a total of 162 to 324 milligrams. Or give one 325 milligram regular strength aspirin tablet, which can be enteric-coated or non-enteric-coated. Finally, tell the person to chew the aspirin completely. If the person takes a prescribed medication for chest pain, such as nitroglycerin, assist them with it. Provide reassurance. Closely monitor the person until EMS professionals take over, and be prepared to perform CPR and use an AED if the person goes into cardiac arrest.
Heat-related illnesses are caused by overexposure to heat and the loss of fluids and electrolytes. Although extremely high environmental temperatures increase the risk for heat-related illnesses, they can also occur at more moderate environmental temperatures. Patrons at aquatic facilities are susceptible to heat-related illnesses, but so are lifeguards. To reduce your risk, stay hydrated. Use umbrellas or shade structures as supplied by your employer. Take your breaks in cool or shaded areas, and rotate more frequently. Heat exhaustion occurs when fluids lost through sweating are not replaced, and other cooling mechanisms become compromised. Signs and symptoms of heat exhaustion include fatigue and weakness, nausea or vomiting, loss of appetite, dehydration, heat cramps, dizziness and possibly fainting, and cool, clammy skin that is pale, gray, or slightly flushed. If not treated, heat exhaustion can turn into heat stroke, which is life-threatening. To provide first aid care for a person with signs and symptoms of heat exhaustion, move the person to a cooler environment with circulating air. Loosen or remove as much clothing as possible. And apply cool, wet cloths to the person's skin, or spray the person with cool water. Fanning the person may also help. If the person is responsive and able to swallow, have them sip a cool fluid that contains electrolytes and carbohydrates, such as a commercial sports drink, coconut water, or milk. If none of these are available, have them sip water. Closely monitor the person and advise them that they should wait to resume activity until several hours after they no longer have signs and symptoms. If the person is unable to take fluids by mouth, has a change in level of consciousness or vomits, or if their condition does not improve after providing first aid care for heat exhaustion, activate the EAP and instruct someone to call 911 and get the equipment. Stop giving fluids, place the person in the recovery position, and continue taking steps to lower the person's body temperature. Monitor the person for breathing, a pulse, and signs and symptoms of shock. Heat stroke occurs when the body's cooling system becomes completely overwhelmed and stops working. Heat stroke is life-threatening. A person experiencing heat stroke may show changes in mental status. For example, the person may be confused, become unresponsive, or have seizures. The person's skin may be pale or flushed. It may feel hot and dry, or slightly moist. Their breathing may be rapid and shallow, and their pulse may be rapid and weak. Other signs and symptoms of heat stroke may include vomiting, headache, dizziness, weakness, and exhaustion. When you recognize signs or symptoms of heat stroke, activate the EAP and instruct someone to call 911 and get the equipment. Then, take steps to rapidly cool the person. Immerse the person up to their neck in cold water to cool them off, if you can safely do so. If you can't immerse the person in cold water, apply cold, wet cloths or towels to the skin. Then apply ice packs and fan the person. You can also have them take a cold shower. If you are not able to measure and monitor the person's temperature, apply rapid cooling methods for 20 minutes or until the person's condition improves. or EMS professionals arrive and begin their care. Monitor the person closely and give care as needed for other conditions that you find.
A stroke occurs when blood flow to part of the brain is interrupted by a blood clot or by bleeding from a vessel, resulting in the death of brain cells. Effects throughout the body are possible, including paralysis, loss of speech, problems with memory, and trouble with thinking. Strokes can cause permanent damage, but with quick action, sometimes the damage can be stopped or reversed. Although strokes are most common in older adults, a person of any age, even a child, can have a stroke. The fast mnemonic can help you easily recognize the common signs of stroke and give EMS professionals crucial life-saving information. Signs that indicate possible stroke include facial weakness on one side of the body, arm weakness or grip weakness on one side of the body, speech disturbance. If you think that a person is having or has had a stroke, activate the EAP and instruct someone to call 911 and get the equipment. After calling 911, note the time of when the signs and symptoms first started. If you do not know when the signs and symptoms started, note the last time the person was known to be well. This is important information to give to EMS professionals. Some medications and procedures used to treat stroke are only effective within a certain time frame after the onset of signs and symptoms. If the person is responsive but not fully awake, drooling, or having trouble swallowing, put them in the recovery position. Then monitor the person's condition until EMS professionals arrive and begin their care.
Shock is a progressive, life-threatening condition in which the circulatory system fails to deliver enough oxygen-rich blood to the body's tissues and organs. Common causes of shock include life-threatening bleeding, infection, and a severe allergic reaction, anaphylaxis. But shock can develop quickly after any serious injury or illness. A person who is showing signs and symptoms of shock needs immediate medical attention. Signs and symptoms of shock include a rapid, weak pulse, rapid breathing, pale, grayish, cool, moist skin, changes in levels of consciousness ranging from unresponsiveness to confusion, restlessness or irritability, nausea or vomiting, and excessive thirst. To minimize the effects of shock, ensure EMS has been called and provide care according to your training for the condition causing the shock. Then have the person lie flat on their back and maintain their body temperature. If they get cold, cover them with a blanket. Or, if they are hot, consider removing a layer of clothing. Administer supplemental oxygen if it is available and you are trained to do so. Never give a person in shock anything to eat or drink. This will help prevent vomiting and aspiration. Finally, provide reassurance and continue to monitor the person's condition.
Injuries to the muscles, bones, and joints include strains, sprains, dislocations, and fractures. You will likely not be able to tell the difference between these injuries, except in the cases of very deformed fractures and dislocations. Just remember two key points. Treat all injuries as potential fractures, and decide if you need to call 911 based on signs and symptoms. A strain occurs when a muscle or tendon is stretched, torn, or damaged. Tendons attach muscles to bones. A sprain occurs when a ligament is stretched, torn, or damaged. Ligaments connect bones to bones at the joint. A dislocation occurs when a bone within a joint moves out of its normal position in the joint. A fracture is a complete break, chip, or crack in a bone. Signs and symptoms of strains, sprains, dislocations, and fractures may include pain, swelling, and bruising, an inability or unwillingness to move the injured body part, an injured body part that is bent, crooked, or otherwise deformed, a popping or snapping feeling or sound at the time of injury, a grating feeling or sound when moving the injured body part, and changes in circulation and feeling like numbness and tingling at and below the injured area. Immediately activate the EAP and instruct someone to call 911 and get equipment if a broken bone is protruding through the skin, there is bleeding with a fracture, there is moderate or severe swelling and bruising, the person cannot move or use the injured body part, the injured body part is bent, crooked, or looks deformed, the person heard or felt the injured area pop or snap at the time of the injury, the person hears a grating sound when attempting to move the injured body part, the injured area or area below the injury is cold, or there is numbness or tingling. The injury involves the head, neck, or spine, pelvis, or upper leg. The person is showing signs or symptoms of shock, including difficulty breathing. The cause of the injury makes you think that the injury may be severe or that the person may have multiple injuries, or it is not possible to safely or comfortably move the person. Then give care according to the conditions found and your level of training. In some cases, you may not need to call 911, but you should still give first aid care and encourage the person to go to the hospital or contact their healthcare provider for further instruction.
Opioids are drugs that are prescribed to reduce pain. The effectiveness of opioid drugs has led to their widespread use, but we have also seen misuse and addiction, increasing the frequency of opioid overdose-related deaths in the United States. Examples of prescription opioids include hydrocodone, or Vicodin, oxycodone, also known as OxyContin or Percocet, oxymorphone, codeine, morphine, and fentanyl. Use of non-prescription illegal forms of opioids such as heroin has also contributed to the increasing number of opioid overdose-related deaths. Opioid overdose suppresses the drive to breathe and can quickly lead to respiratory failure, respiratory arrest, or cardiac arrest. Signs and symptoms of opioid overdose include the presence of items associated with drug use such as prescription pill bottles, pipes, needles, syringes, or pill powder. Decreased breathing effort, for example, breathing slowly and perhaps only a few times per minute. Gasping or gurgling. Bluish or grayish skin. A decreased level of consciousness or unresponsiveness. And pinpoint pupils. If you recognize signs and symptoms of opioid overdose, immediately activate the EAP, instruct someone to call 911 and get the equipment, and consider naloxone administration in accordance with your facility's protocols. Naloxone, a drug that temporarily reverses the effects of opioids, is given through the nose as a mist or a spray. You may administer naloxone that is stocked at your facility if allowable by state laws and regulations and you are trained and authorized to do so. Under some state laws and regulations, you may also administer naloxone that is prescribed to the person. An opioid overdose may not be obvious. If you suspect an opioid overdose, or if opioid overdose is known, care for conditions found and consider naloxone if the person is responsive but has a decreased level of consciousness. Or the person is unresponsive but is breathing normally and has a pulse. For a person in respiratory failure or respiratory arrest as a result of opioid overdose, give ventilations at a rate of 1 ventilation every 6 seconds for adults, or 1 ventilation every 2 to 3 seconds for children and infants. Administer naloxone as soon as it is available and resources permit. You may also administer emergency oxygen if it is available and you are trained to do so. For a person in cardiac arrest as a result of opioid overdose, prioritize CPR and AED use. Administer naloxone when it is available and resources permit, but do not delay or pause CPR or use of an AED to do so. After giving naloxone, note the time it was administered. If the person is still having signs and symptoms 2 to 3 minutes after administering the first dose and EMS has not arrived, administer a second dose. Monitor the person until EMS arrives and begins their care.
A poison is any substance that causes injury, illness, or death if it enters the body. Signs and symptoms of a poison exposure vary depending on the type and amount of poison taken into the body and the way it enters the body. A person exposed to poison may experience abdominal pain, nausea, vomiting, diarrhea, abnormal skin color, and sweating. They may also experience life-threatening conditions such as trouble breathing, fast or slow breathing, fast or slow heart rate, unresponsiveness, changes in level of responsiveness, seizures, headache, dizziness, or weakness. If the person shows signs and symptoms of a life-threatening condition, or if multiple people are affected, immediately activate the EAP and instruct someone to call 911 and get the equipment. If the person is responsive and alert, call the National Poison Help Hotline at 1-800-222-1222 and give care as advised.
A bag valve mask, or BVM resuscitator, is a handheld device used to give ventilations. The BVM resuscitator has a mask that is connected by a one-way valve to a self-inflating chamber or bag. Squeezing the bag with the mask properly sealed over the person's mouth and nose forces air into the person's lungs. Releasing the bag causes it to self-inflate by drawing air in from the other end. A BVM resuscitator can be used with or without supplemental oxygen. There is an oxygen inlet for attaching the resuscitator to a supplemental oxygen source and a reservoir that fills with oxygen. You can also use a HEPA filter with a BVM resuscitator to provide additional protection from pathogens and exhaled air. BVM resuscitators are sized specifically for adults, children, and infants. 2 rescuers are needed to most effectively operate a BVM resuscitator. One rescuer seals the mask and opens the airway, while the other rescuer squeezes the bag to deliver ventilations.
I'll manage the airway while Matt delivers ventilations.
To begin, select an appropriately sized BVM resuscitator and assemble it if necessary. To assemble a BVM, attach the appropriately sized mask to the bag. If you are using a HEPA filter, attach it to the mask and then attach the bag to the mask assembly. Place and seal the mask and open the airway. The second rescuer delivers ventilations by gently squeezing the bag about halfway. Both rescuers watch for the chest to rise. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. Provide smooth, effortless ventilations that last about 1 second and cause the chest to just begin to rise. Providing ventilations too fast or with too much volume can be dangerous. Remember, the rate for giving ventilations varies. When providing ventilations as part of the rapid assessment for a drowning victim who is not breathing, or during CPR, deliver one ventilation, allow the air to exit, and then deliver the second ventilation.
Breathe.
When providing care for respiratory arrest or failure, deliver one ventilation every 6 seconds for an adult.
5 1,000. Breathe. 1 1,000. 2 1,000. 3 1,000. 4 1,000. 5 1,000. Breathe.
And one ventilation every 2 to 3 seconds for a child or infant.
1 1,000. 2 1,000. Breathe.
The air we normally breathe contains 21% oxygen. When a person is having trouble breathing, having them inhale a higher than normal percentage of oxygen is helpful. Emergency oxygen increases the oxygen content of the air provided to the victim. Emergency oxygen can be given for many breathing and cardiac emergencies. It can be given to non-breathing victims as well as to those who are breathing on their own. Emergency oxygen should only be administered as a secondary treatment after the priorities of airway management, ventilation, CPR, use of an AED, and bleeding control have been addressed. Always follow local protocols for administering emergency oxygen. There are two types of oxygen delivery systems: variable flow rate systems and fixed flow rate systems. Always follow the manufacturer's instructions for using the oxygen delivery system that you have.
Variable flow rate oxygen systems allow the rescuer to adjust the flow of oxygen based on the victim's need. Variable flow rate delivery systems must be assembled by the rescuer
and include an oxygen cylinder, a pressure regulator with a pressure gauge and flow meter, and a delivery device.
Types of delivery devices include nasal cannulas, resuscitation masks with oxygen inlets, simple oxygen face masks, non-rebreather masks, and BVM resuscitators. First, make sure that the oxygen cylinder is labeled USP for United States Pharmacopoeia and marked with a yellow diamond that says oxygen. Next, clear the valve. To clear the valve, remove the protective covering and the O-ring gasket if present. Turn the cylinder away from yourself and others, and open the cylinder valve for 1 second to clear it of any debris. Now, attach the pressure regulator. If you remove the O-ring gasket, put it into the valve on top of the cylinder. Then, check to see that the pin index on the pressure regulator corresponds to the oxygen cylinder. Secure the pressure regulator on the cylinder by placing the 2 metal prongs into the valve and tighten the screw by hand until the regulator is snug. Open the cylinder with 1 full turn counterclockwise and check the pressure gauge to verify that the cylinder has enough pressure. If the pressure is less than 200 psi, do not use the cylinder. Attach the plastic tubing between the pressure regulator and the delivery device. Turn the flow meter to the desired flow rate and make sure the oxygen is flowing. Block the one-way valve on the mask with your thumb to allow the reservoir to fill. Then place the delivery device on the victim. I'm going to put this on you now, okay?
Okay.
Just breathe normally. Continue to monitor the victim and give care according to your training until EMS arrives and takes over. To use emergency oxygen when delivering ventilations with a BVM resuscitator, attach one end of the plastic tubing to the oxygen port on the regulator, and then attach the other end to the oxygen port on the resuscitator, like this. Then operate the BVM resuscitator as you normally would. One, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. To break down the oxygen delivery system, reverse the assembly steps. After the cylinder has been turned off, turn on the flow meter to bleed the pressure regulator. Fixed flow rate systems deliver a preset or fixed flow of oxygen to the person. Although they are limited in the concentration of oxygen that can be provided and in delivery device options, they are pre-assembled. To use a fixed flow rate oxygen system, simply turn it on according to the manufacturer's instructions, check that the oxygen is flowing, and place the delivery device on the victim.
When someone is unresponsive, is not breathing or only gasping, and has no pulse, it is critical to begin CPR right away. CPR consists of 30 chest compressions, followed by 2 ventilations. Compressing the chest and allowing it to return to its normal position moves blood carrying oxygen to the brain and other vital organs. First, ensure that the person is on their back on a firm, flat surface, such as the ground. Next, kneel beside them, like this, with your knees near the person's body and spread about shoulder width apart. Place the heel of one hand in the center of their chest with your other hand on top. Now, interlace your fingers and make sure they are up off the chest. Then, position your body so that your shoulders are directly over your hands. Lock your elbows to keep your arms straight. This technique allows you to use your body weight to help compress the chest. You are now in the correct position to give compressions. When giving compressions, push hard and fast. Compress the chest to a depth of at least 2 inches and a rate of between 100 and 120 compressions per minute, or about 1 every half second. After each compression, let the chest return to its normal position. Watch as I demonstrate just a few chest compressions so you can see what they look like. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10. Now it is time to put the skills you have just learned, giving chest compressions and giving ventilations, together in order to give cycles of CPR for an adult. Each CPR cycle consists of 30 chest compressions followed by 2 ventilations. Remember, it is important to begin each CPR cycle with chest compressions. However, if drowning is the suspected cause of cardiac arrest, deliver 2 initial ventilations before starting CPR cycles. Also, make sure you smoothly transition between chest compressions and ventilations. Interruptions in compressions to give ventilation should be as short as possible, taking less than 10 seconds. Okay, now watch as I put chest compressions and ventilations together to perform 2 cycles of CPR. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
CPR for a child is essentially the same as CPR for an adult, with 2 small differences. First, compress the child's chest to about 2 inches instead of to at least 2 inches. Second, when giving ventilations, open the airway to a slightly past neutral position instead of to a past neutral position. As for an adult, each CPR cycle for a child consists of 30 chest compressions followed by 2 ventilations. And, just as you would for an adult, compress the chest at a rate of between 100 and 120 compressions per minute and allow for full chest recoil. For a small child, you may only need to perform chest compressions using 1 hand instead of 2. When using 1 hand, be sure you're able to compress the chest about 2 inches. Simply place the heel of 1 hand in the center of the chest and give compressions. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. For a child or an adult, once you begin CPR, do not stop. Continue CPR until you see signs of ROSC, such as movement, breathing, or coughing. An AED is ready to analyze the heart rhythm. Other trained providers take over and relieve you from giving compressions and ventilations. you're too exhausted to continue, or the situation becomes unsafe.
Our heart is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, the brain, vital organs, and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. The power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens when we don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood, therefore not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood, therefore no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can, and don't give up until medical help arrives or an AED is present. You can do it.
When a person is in cardiac arrest, early use of an AED can help restore a normal heartbeat. For each minute CPR and defibrillation are delayed, a person's chance of survival decreases by 7 to 10%. If you are the only rescuer available to operate the AED, turn on the AED as soon as it is available and follow the voice prompts.
Attach pads firmly to person's bare chest as shown.
Remove all clothing covering the chest to place the AED pads and wipe the chest dry if necessary. First, always use adult AED pads on anyone older than 8 years of age and/or weighing more than 55 pounds or 25 kilograms. Do not use pediatric AED pads because the shock delivered will not be sufficient. Then, place one pad on the upper right side of the chest. And the other on the lower left side of the chest, a few inches below the left armpit. Follow the diagrams and labeling of where each pad goes. If the AED pad has a feedback device, follow the manufacturer's instructions for use.
Plug-in connector.
Plug the pad connector cable into the AED if necessary, and prepare to let the AED analyze the heart's rhythm. Make sure no one, including you, is touching the person. Say clear in a loud commanding voice.
Don't touch person. Analyzing.
Clear. Be ready to deliver a shock if the AED determines one is needed.
Shock advised. Press flashing shock button.
Again, make sure no one, including you, is touching the person and say clear in a loud commanding voice. Clear. Push the shock button to deliver a shock if the AED determines one is needed. After the AED delivers a shock, or if no shock is advised, immediately start CPR, beginning with compressions.
Shock delivered. Start
1
CPR.
and 2 and 3 and 4 and 5 and 6 and 7 and 8. Continue giving CPR cycles until the AED prompts that it is reanalyzing. You see signs of ROSC, such as movement, breathing, or coughing. Other trained providers take over and relieve you from giving compressions and ventilations. You are too exhausted to continue, or the situation becomes unsafe.
For anyone up to 8 years of age, including infants, or weighing less than 55 pounds or 25 kilograms, follow these pediatric AED guidelines. Use pediatric AED pads to deliver a lower energy dose. For children, position these pads as depicted in the diagram. If pediatric AED pads are not available, it is safe to use adult AED pads. However, the AED pads should never touch each other when applied, like this. So if it appears that the AED pads would touch each other, place one pad in the middle of the chest and place the other pad on the back between the shoulder blades. When using an AED on an infant, always use the front-back pad placement. To do this, apply one pad in the middle of the infant's chest and the other pad on the infant's back between the shoulder blades.
When there are two rescuers, the steps for using an AED are the same, but one rescuer performs CPR while the other operates the AED. Teddy is here to demonstrate with me how to use an AED when there are two rescuers. After completing the rapid assessment and recognizing that the person is in cardiac arrest, I'll begin care as the other rescuers arrive to assist.
When I arrive with the AED, I'll set it up while Francis continues CPR.
That's right. I won't pause CPR until the device is ready to analyze the person's heart rhythm.
After I deliver the shock, or if no shock is advised, we'll switch roles.
And we'll continue CPR. Watch as we demonstrate these steps. And 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10.
EMS has been called. I have the AED and I'll set it up.
17, 18, 19, 20, 21, 22, 23, 24,
Attach
25,
pads firmly
26,
to person's
27,
bare chest
28,
as shown.
29, 30. One and 2 and 3 and 4 and 5 and 6
Plug in
and 7
connector.
and 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18,
Don't
19,
touch
20,
person.
21,
Analyzing.
22.
Clear. I'll take over the next round of compressions.
Shock advised. Press flashing shock button.
Clear.
Shock delivered. Start
1
CPR.
and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14, 15.
After the shock was delivered, we switched roles.
You should switch roles like this about every 2 minutes, taking less than 10 seconds to minimize interruptions to chest compressions.
This video is intended to help you understand how an AED works. The ECG strip you are going to see is from Steve's actual save, a real person who is alive today because of an AED and some good Samaritans who took action. Once you turn on an AED, the machine will begin to speak to you. Follow the voice prompts. Once the pads have been placed, the AED will instruct you to stand clear and to not touch the patient while it does an ECG of the heart. The AED is designed to determine if the heart is in a normal rhythm or if it needs to be shocked. In this case, the heart is in ventricular fibrillation, the most common rhythm when someone goes into sudden cardiac arrest. Notice how the heart is not beating effectively. It has electrical activity, but it is uncoordinated. The heart looks like it is shaking like a bowl of jelly. When in this rhythm, you can see the heart is not effectively pumping any blood out. This rhythm is deadly and has to be stopped. When the AED reads a shockable rhythm, the AED will either instruct you to press the shock button, or some AEDs are automatic and will automatically shock the person. At this point, no one should be touching the patient. The AED will send an electrical current through the heart and back again. The purpose of this shock is to stop the heart completely for a very short period of time from this uncoordinated rhythm and give it time to reset. Notice how the shock stopped all the electrical activity in Steve's heart for a brief period. Seconds after this shock, our own SA node, the pacemaker of our heart, will try to regain control of the heart and tell the rest of the heart when to squeeze. It can take up to 2 minutes for the heart to reorganize itself electrically after a shock, before it will function again and effectively pump blood to the brain. This is why you will be instructed to begin CPR immediately after the shock. Your job is to push hard and fast in the center of the chest in order to manually pump blood to the brain, to keep the brain alive. Your compressions will not interfere with the heart trying to reorganize itself electrically, so do not worry about that. After 2 minutes, the AED will instruct you to stop CPR. It will reanalyze the heart and advise whether another shock is needed. Always listen to the machine and follow the voice prompts. In Steve's case, the ECG picked up a healthy rhythm and therefore a second shock was not advised. In Steve's case, only 1 shock was required to bring him back to life. Steve's heart continues to beat and he is alive and with us today.